Good afternoon, and thank you for joining us today. We are very thrilled to welcome you to this insightful session on catheter-based closure of PDA. We encourage you to engage actively, ask questions, put them in the Q&A box, share your experiences, because your participation and enthusiasm will greatly enrich our session. So our speaker for today is Dr. Adrianne Bischoff. She is a clinical assistant professor of pediatrics and neonatology and a neonatal hemodynamic specialist at the University of Iowa Stead Family Children's Hospital. Her area of academic focus relates to physiology following definitive PDA closure and the use of TNE, which is targeted neonatal echocardiography, in different disease states that impact morbidity in preterm and critically ill neonates. Helping me moderate today is Dr. Michael Castaldo, and we will hand over the stage to Dr. Bischoff.
Thank you for that introduction, Marjorie. Just double check here with me that my slides are coming up in the correct format. Are we good?
Yes, they are.
Perfect. Thank you again for the invite on talking about this topic that is very close to my heart and that I try to do some good work and lots of work in. I think there's so much more that we need to learn, and I am no expert in this by any means, but at least I am in tune with some of the literature and I have done some work, and I guess that's why they keep inviting me to talk about this. So we'll talk about a couple of different aspects of PDA closure, including both surgery, but most modernly cath closure, and how do we take good care of these patients in the periprocedural period. So this is a study that we published last year on the impact registry from the NCDR, where we included almost 1,600 babies that were less than 2 kilos at the time of percutaneous PDA closure. And what you can see here in these figures is that there was an extreme high incidence of technical success and a very small number of what were considered to be major adverse events in this contemporary practice, showing that this technique is expanding and the learning curve for people that are performing this procedure continues to improve over time. When we did some multivariable analysis, we showed that the hospitals performing a higher number of these procedures in small babies had a smaller odds ratio for the primary outcome, which was a composite of technical failure and or major adverse events. And you will see that I'm going to highlight this kind of finding a couple of times throughout the presentation, because having centers of excellence that are performing a critical mass of these procedures is probably very relevant for us to continue to move forward in a safe way for our tiniest babies. Earlier, a couple of years ago, we also did a meta-analysis at the time in 2020 when the Piccolo device had just been approved by the FDA, looking at the outcomes of patients that were less than 1.5 kilos at the time of closure. And what you can see on the graph on the left is that there's been an increase in the probability of technical success over time, where it was less than 90% in the years of the mid 2000s, and then went up to 98% in the most recent years. And that has been accompanied also by a trend in this procedure being done in progressively smaller patients. So what you can see on the graph on the right is that we didn't have the date of the procedure, we only had a year of publication, but as the years went by, the technical success, the estimated probability of technical success went up, while we have more and more babies in the lower bottom part of the graph showing that they are progressively smaller, and some of them are reported to be even closer to the 500-gram threshold for doing this procedure. So kudos to our interventionalists who are publishing and showing us their results in this population and in becoming very good at doing this in some of our most vulnerable patients that might benefit the most from this type of procedure. Very recently, earlier this month, this study was published, and one of the new trends that we have to look is what is going on with this new era of transcatheter closure compared to the old era where surgery was the primary modality for definitive closure. So to date, this is the largest cohort study comparing PDA cath closure to surgery in preterm infants, and the data comes from the Vermont-Oxford network, which included 3,393 patients undergoing transcutaneous closure and almost 3,000 patients that underwent surgery. And what you can see on the graph on the left is that there's an increase in the transcatheter device use from what used to be about 30% in 2018 to over 70% in 2022, showing that there's a shift in the clinical management strategy with an increasing trend of transcatheter closure, but a relative consistent absolute numbers of annual ductal closures, which means that TCPC is seen to be preferable to surgical closure for many of these VLBW infants with a hemodynamically significant ductus, but perhaps not sufficiently benign to result in an overall increase in the total number of invasive interventions. And what you can see on the table on the right side is that those VLBW infants that underwent transcatheter closure had higher survival, but had similar length of stay, neonatal complications, and receipt of discharge support. I recommend that everyone takes a look at this article in a bit more detail, because there are other nuances that we won't have time to talk about. But for example, the age at transcatheter closure tends to be much later than surgery. So people are more likely to do surgery in those smaller, younger babies, and then catheter closure tends to be reserved for babies that are a little bit older and a little bit bigger still. So moving away from outcomes, I wanted to spend a little bit of time on the part of the precision care and where does the neonatologist come from and what do we need to do for our patients that are going for PDA closure. And I put percutaneous PDA, but because that's the main modality that we are doing here in the United States, but that could apply for surgical closure as well. So first of all, of course, we are going to focus on what's the patient selection for this procedure. First, are these patients patients that had a failure of medical or repeated medical therapy, or they have contraindications to further medical therapy? Do they have symptoms that are consistent with respiratory compromise and or systemic hypoperfusion? We want to make sure that there are no other conditions that might be predisposing them to worse shunt manifestation, for example, infection. Specifically for percutaneous closure, we want to make sure that there's morphological suitability for the device. So sometimes PDAs that might be too short or too small on the PA end potentially may not be the ideal type of ducts to be closed through an endovascular approach. And then I suggest that everyone moves towards a comprehensive assessment of shunt volume and significance. And this is important because there's two very different scopes of practice, right? Well, the most common one is to treat ductus that are symptomatic based on, the baby who is on the ventilator or who is on oxygen. Our practice here at the University of Iowa is predominantly echo-based and based on an individual risk profile. So frequently patients that might be even pre-symptomatic. So yes, we will close babies that are on CPAP in 21%. If by echo features and by their individual risk profile, we feel like these babies would benefit from a definitive approach. Going a little bit further in how we do this, we have an early screening and targeted PDA management approach here in Iowa, and all of our babies that are under 30 weeks will get an echo early in their life. And obviously this is not cookie cutter. But overall, our first modality of treatment is acetaminophen for the little ones in the first week of life, and then typically followed to up to 2 courses of indomethacin. But obviously, if there is no improvement with the therapies or if there are contraindications, sometimes we go for definitive closure earlier than this. Or if it's a remitting, relapsing type of course, which is the majority of the babies that we send for cath closure these days, then this type of therapies might change a little bit, but that's kind of the gestalt of how we do things around here. And this is the PDA score that we use here in Iowa, looking at measurements of systemic hypoperfusion as well as pulmonary overcirculation. This is by no means an absolute way of you must do it this way and you must have a certain amount of points, but it's good for the inter-rater between ourselves and also within the same patient to kind of get a sense of what the trajectory of the shunt is doing and to define if this is a shunt that actually does meet criteria and we should proceed with definitive closure or therapies in general. When we're going to talk about pre-procedural preparation, it is standard of care here that we always have to have arch-sidedness and ductal patency confirmed pre-operatively, of course, and the suitability for percutaneous closure. So for the most part, these procedures are done in the morning or afternoon here. So we try to do an echo on the day, even if it's a limited echo, just to confirm that the duct is actually still there, it's still a problem, and we should proceed with everything else. Occasionally we do this the day before if the procedure is done too early in the day. All of our babies have secure vascular access. Typically it's a PICC line plus a PIV for anesthesia purposes. We want to make sure that they are not anemic or thrombocytopenic and that we don't need to transfuse them ahead of time. We frequently will do an ACTH stim test and we'll give hydrocortisone, whether stress dose or maintenance. That's debatable. This is an individual practice here at our center based on how our faculty group came together and decided to proceed. But I have no data to suggest that this is what everyone should be doing and why this is done, but this is how we do it here. And we do consider placing our arterial line if the baby no longer has a UAC. We do it on the arms because it's easier access than the feet when the baby's in the cath lab. But we only do that for the patients that we deem to be at higher risk for post-closure cardiorespiratory instability, which we will talk about a little bit further later on. So typically babies that are less than a kilo or definitely less than 750 grams, we will for sure want an arterial line for closer monitoring and labs and so on and so forth. Here at the University of Iowa, we do optimize these patients from a respiratory standpoint before they go to the cath lab. So we get an x-ray in the morning to make sure that the breathing tube is in the right placement. They go already intubated from the NICU. We tend to intubate our own patients here and not leave it to anesthesia. And then we sedate and muscle relax our patients in the unit and then adjust their vent settings even before they are mobilized. And the reason for that is that over 70% of our patients here are on high frequency jet ventilators. And obviously that's not the expertise of the anesthetic team. And it might be really challenging to manage that if you don't have a neonatologist around. So we want to make sure that the settings are already what the baby needs in that state of sedation and muscle relaxation. And that way anesthesia basically just has to rebolus the patient to keep them sedated for the duration of the procedure. We send a multidisciplinary team with our baby. As of today, we are still doing this procedure in the cath lab, hoping to move towards bedside closure, which we might have a discussion in the panel later. But we do mobilize these babies, like I said, on the jet ventilator, and we pay special attention with, temperature and tube position and all of that stuff. We do have a multidisciplinary team that goes and then a senior fellow or a hemodynamics fellow that goes mostly to manage the jet and provide any assistance if necessary during the case. I will say that for the most part, they just go and watch the procedure because there's not much that needs to be done. But we do believe that that's a good safety net for these very tiny babies that need very specialized care. And then we pay a lot of attention when we're moving the babies to the bed and getting that first echo in the cath lab again to confirm the PDA, measure the size, which is helpful for choosing the right device. The femoral vein access is ultrasound guided. And then again, there's another transthoracic echo mid-procedure to confirm the placement of the device and make sure that there's no major protrusion into the adjacent structures even prior to the deployment of the device. And then what we tell our fellows that are there to keep an eye on, which are the main risks, I kind of listed there on that red box. But what we most commonly see is sometimes there's a very transient change in vital signs, either immediately after deployment or when the catheter is still lodged kind of in the pulmonary artery. And typically that goes away fairly quickly. And to be fair, the more we do this procedure, the less of that transient change in vital signs we have been seeing. And most of these babies are extremely stable throughout the entire procedure. While we do know that there's a trend that it's likely to continue for us to perform the procedure more and more and expand this practice, there are some gaps in the literature, and we identified that when we did our meta-analysis. And one of the important metrics that we need to discuss pertains to the incidence of PDA, post-PDA closure instability. So going a little bit into the physiology of this, in the presence of a significant left to right PDA, obviously there is pulmonary overcirculation, and the LV is exposed to a relatively low afterload because the PDA is connected to a low resistance circuit, which is the pulmonary vasculature. Once the PDA is suddenly closed, there's obviously big changes in loading conditions. So there's a sudden decrease in left heart preload, but also a significant increase in left heart afterload, because now the LV is only exposed to the systemic vascular resistance. And these changes will eventually lead to a lower left ventricular output. This is one of our babies here from the early days of cath closure, where you can see an apical four-chamber view with a very dilated left heart because of that PDA. And then 1 hour after the procedure, it kind of looks like a deflated balloon where there's less volume loading, and you can actually appreciate that there's some reduced LV systolic function. So what we traditionally call post-ligation cardiac syndrome is a disease characterized by LV failure because of a high afterload state. And the full spectrum includes cardiovascular instability, which was initially characterized by systolic hypotension because of a decrease in the stroke volume and or the need for inotropic support following PDA surgery, and respiratory instability, whether due to ventilation or oxygenation impairment. And although we all can agree that transcatheter closure is much less invasive than open surgery, there's definitely less potential for inflammatory stimulus. There's no manipulation of the lung, none of that. The changes in loading conditions are the same, and therefore the babies are still at risk for this condition. But from now on, you will see that I have adapted the name to be called post-transcatheter cardiorespiratory syndrome. So if I say PTCS or PLCS, they're kind of interchangeable, just talking about this kind of condition. So what we know from this condition is that the impairment in LV systolic performance also coincides with the clinical deterioration that these patients have. And it typically happens within 6 to 12 hours after the procedure. So the baby comes back looking great and then might start getting sicker, obviously for that fellow that is on call in that evening. And you can see that from one of our studies here at our center, that there are significant changes that we can see on echo in left heart volume loading measurements, and then also in LV systolic and diastolic function already within the first hour after the PDA is closed. Clinically, what we see immediately after closure is that the diastolic blood pressure tends to go up, which is the reflection of the loss of that systemic steal from the PDA. And there's also a concomitant increase in both the systolic and the mean blood pressure. And what you see on the right is data here from our group, where you can see again that the diastolic blood pressure rises immediately after cath, which is the difference between the first two dots, and continues to rise over the next 24 hours. This is a multi-center study that we published a couple of months ago, where we had 4 different sites enrolled, and we collected detailed information of their vital signs after PDA closure. So kind of to prove that this is not a phenomenon that just happens here at Iowa. It actually happens to a lot of patients in the different centers with slightly different practices. You just have to be able to look carefully to kind of notice the patterns. And you can see that the systolic, the diastolic, and the mean blood pressure do go up on these babies over time. Arguably, of course, there is probably some effect of sedation wearing off, but I would find it very surprising that this would continue to go up over a 24-hour period if it was just a matter of that very brief sedation period that the baby got in the cath lab that was impacting these findings quite dramatically. When we're talking about this post-closure cardiovascular instability, the typical course would be, for those that do have it, is that after an initial period of stability where there's higher blood pressure when you compare it to the baseline, there's a progressive decline in the systolic blood pressure. But you can see that the mean blood pressure during that period remains relatively stable because the diastolic is normal or is high. And that's why it's important for people that are at the bedside, and that's why we have to do education with our nursing staff, that they need to pay attention to all of the components of the arterial blood pressure. Because if this kind of window goes unrecognized, and again, like I said, it's typically between 6 and 12 hours, if the disease progresses, then you have subsequent decrease in all of the components of systolic, diastolic, and mean blood pressure because of left ventricular failure. Not all hypotension fits the phenotype for post-closure cardiovascular instability. So if there's a patient that develops early hypotension in the first 1 to 2 hours or predominant diastolic hypotension, that's typically not part of the spectrum of this disease. And if that's the primary pattern that people are seeing, then other causes need to be taken into consideration. So how do we explain how these changes will affect the LV? Looking at the Frank-Starling law, the majority of the infants that we're sending for PDA cath closure are likely falling into this part of the curve, where they are going from a place of a volume-loaded left heart to a condition of normal loading. If you had a baby who had relative hypovolemia before PDA closure, whether they were fluid restricted or because they were using a lot of diuretics, then that change in preload would actually cause an immediate decompensation post-closure, which is not what we would typically see. So that's why we recommend that these babies are optimized from a fluid standpoint so that they are on the correct side of the curve and they don't fall off the cliff as soon as the PDA gets closed. What we see most commonly, and what's the main determinant, are the changes in afterload and the stress velocity relationship. So the effect of afterload on heart function depends on sustained exposure, leading to a low cardiac output state, particularly in those babies that have more vulnerable and immature myocardiums. And that explains why the clinical manifestations that you see as part of PLCS typically happen 6 to 12 hours after closure. So it's the analogy that Dr. Giesinger always taught us, that if you go to the gym and you are lifting 10 pounds and all of a sudden now you got 20 pounds, you probably can cope with it for a while, but over time that muscle kind of fatigues, and that's when you get the low cardiac output state and some degree of LV systolic dysfunction, and then the clinical manifestations of low cardiac output. Moving on to the respiratory impact of PDA closure, it's what we are all aiming to achieve for the most part with definitive closure, is the cessation of left to right shunt, which is accompanied by an immediate improvement in lung compliance. And you can see from one of the very few studies that report this, that ventilatory parameters do improve quite substantially before and after closure. However, and again, this is data from our multi-center study, what some of the patients will do is that after that initial improvement in mean area pressure and in FiO2 or respiratory severity score, which is just mean area pressure times FiO2, there is a subsequent secondary increase in a subset of patients, not all of them, in the FiO2 and the respiratory severity score over time. And our hypothesis for this, that the likely mechanism that is implicated is related to some diastolic impairment with a secondary increase in left atrial pressure, pulmonary venous hypertension, and then pulmonary edema that ensues. What we've noticed in these babies that go for PDA cath closure is that the respiratory phenotype is pretty common and more prominent than the traditional cardiovascular instability. So when you look at all these studies that were initially reporting that PLCS doesn't happen in cath closure, that if you pay close enough attention, you will see that they might be referring to the traditional cardiovascular phenotype, where there were less hypotension, less need for inotropes. But these studies were not defining the respiratory phenotype, which for us as neonatologists is very, very relevant. So here's an example of a baby that pre-closure was, very wet looking X-ray on conventional settings and an FiO2 of 35%. 1 hour after the procedure, you see that the lungs look a lot clearer. The FiO2 is kind of stable. The mean air pressure is a little bit down. The settings are a little bit lower. But then 12 hours post, this baby actually had failure to maintain his CO2 clearance with conventional ventilation and needed to go to high frequency jet, is on higher FiO2, and the lungs have more pulmonary edema again. So there's progressive pulmonary edema, and in this case, there's both oxygenation and ventilation failure. We did a study early on in the course here from patients here at the University of Iowa that were less than 2 kilos at the time of closure. And we showed that nearly 50% of our babies had some degree of instability, and that the main component, which was present in more than 40% of these small babies, was characterized by oxygenation failure. And what you can see here in more details on the graph is that the darker bars will represent the babies in which there was that significant increase in respiratory severity score. And that was particularly after 6 or 12 hours after PDA closure, which again coincides with that time frame for clinical instability that had been originally described in PLCS in the babies undergoing surgical ligation. In the surgical patients, PLCS was more common in those that had lower weight at the time of the procedure, as well as younger postnatal age. And what this graph is very interesting is that it shows that the PLCS risk goes down from as high as 50 to 60% when it's performed in the first week of life, and then drops to less than 10% when it's performed after 30 days. And again, this is a very important consideration for anyone reviewing this literature and looking at the studies that report post-closure instability, because you need to assess that risk in the context of the baseline risk for the patient. So if you say that you found a low incidence of PLCS, but all of the babies in the study were 1.5 kilos and they were 30, 40, 50, 60 days old at the time of closure, that doesn't surprise me at all, because I already knew that that would be their risk profile if they were undergoing surgery as well. But if the babies are young and they are small, then I'm more interested to see if the PLCS risk is similar to the surgical babies or if it's actually different when undergoing cath. When we looked again at our own patients that were undergoing cath closure here, they seemed to be smaller and younger at birth at the time, but the age of the procedure and weight at intervention were not statistically different in those that did develop some sort of PLCS or didn't. But what you can see here is that those that were more likely to have worsening cardiorespiratory status following PDA closure also had worse parameters for lung disease even prior to the procedure, meaning you had worse lungs even before you went for closure, you are more likely to have that secondary oxygenation ventilation impairment post-closure. And again, similar to what the surgical studies saw, and unlike what a lot of people actually think, the severity of the shunt or the size of the shunt were not significant predictors to define which were the babies that were more likely to get sick after closure. In our multi-center study, we have included in our definition for PTCS, the occurrence of systolic hypertension following closure, because we noticed that that was quite prominent phenotype. And when we put them together, cardiovascular instability plus respiratory instability, our incidence in that study was of 23%. And if you look at the individual components, again, you can see here that ventilation oxygenation failure happens in about 40% of the babies, which is very similar from our single center experience, and that post-procedural hypertension is quite significant at 43% of these patients. And this is, we're talking only in the first 24 hours after the procedure. And when we look at the traditional things, which were hypotension or need for inotropes, indeed, in the cath closure population, that is fairly infrequent, and only 14% of the babies do develop those kind of manifestations. This is the graph that we published that shows the 4 different centers. Of course, they are blinded because there's no need for anyone to know where the babies come from. But you can see that the composite of oxygenation or ventilation failure is fairly common in all the 4 sites. Ventilation failure might be different because of different ventilator practices and how the definition is done. But then again, the composite of cardiovascular can be quite different depending on some of the individual practices of these centers. And what I mean by that is that when you look at the logistic regression models for the risk of PTCS, what we did find was that, again, weight at catheterization and respiratory severity score pre-procedure did impact on the risk for the development of PTCS, whereas the center use did not, but the use of Mirinone prophylaxis was also very different in the centers, and that might not be well accounted here in this kind of graph. So let's talk a little bit more about echo predictors of PLCS or PTCS. Looking at the original surgical studies and the echo predictors of PLCS, we know that left ventricular output at 1 hour correlated with the LVO at 8 hours and was also associated with low systolic arterial pressure and the need for inotropic agents. And this is what provided the groundwork for the use of early prophylactic Mirinone in the babies that had low LVO after PDA ligation. This was the original EPOC study from the Sick Kids group that showed a decrease in the need for postoperative inotropic support and a drop in the incidence of PLCS from 44 to 11% after they instituted a protocol using this targeted Mirinone prophylaxis approach. And because Mirinone has vasodilator, inotropic, and lusitropic properties, it is a very appealing agent for this disease that is caused by high afterload, impaired LV performance, and diastolic dysfunction. When we're talking about the diastolic part of it, as you know, the opening of the mitral valve is dependent on the pressure gradient between the left atrium and the left ventricle, such that when the left atrial pressure supersedes the LV pressure at a time when the LV is relaxing and it's empty. So in the meantime, the left atrium is being continuously filled by the pulmonary veins. If you do have diastolic dysfunction, the LV pressure remains high for a longer period of time because even though the contraction has ended, the heart is very stiff, and therefore it takes a longer time until the left atrial pressure is big enough to open that valve. And that's why, for those of you that are familiar with echo, that's why the IVRT prolongs. We also looked at a study a few years ago, looking at other parameters that are similar-minded in this type of population. And we found that after PDA closure, there was a drop in preload, an increase in arterial elastance, and an increase in end-systolic elastance. And there were some correlations that suggest, again, that that diastolic phenotype and changes in preload are part of the pathophysiology for PLCS. Another important aspect, specifically when we're talking about diastolic dysfunction, the risk of respiratory deterioration from this cardiac lung origin, and the newfound risk for systemic hypertension, at least in the short-term period, you won't find much literature about it, but we do know that the blood pressure does go up. And we hypothesize that this might have to do with the renin-angiotensin-aldosterone system. So what we speculate is that in those immature kidneys that are chronically underperfused, there may be an upregulation of the system in order to maintain perfusion pressure. And when there's a sudden improvement in that post-ductal perfusion, perhaps there may be some time for these receptors to readapt, and that's why these babies may be predisposed to developing secondary systemic hypertension. All of this is speculative, and there's more work to be done in this area. So back to a little bit more practical and things to pay attention in that post-procedural care, things that we recommend and that we practice around here. The first one is close attention to that new lung compliance after closure. You can see that baby from the picture there, that once the baby comes back from the cath lab, you have to back off on the mean airway pressure because they might be at risk for becoming overexpanded and actually compress their heart and impair their preload even further if you don't change the mean airway pressure and the ventilator settings. We here at the University of Iowa continue to do our targeted Mirinone prophylaxis approach, similar to what we used to do in the surgical babies. So we do an echo 1 hour after closure, and then we guide our Mirinone prophylaxis similar to what was being done in the surgically ligated babies. We typically will do an X-ray later on in the day to monitor for those changes in respiratory status so that we can perhaps catch on any nuances in the compliance of the lungs even before the baby starts developing too much oxygenation or ventilation impairment so that we can change the ventilator settings preemptively before the baby becomes too sick. And then we pay close attention and we provide guidelines for both the nursing staff as well as the clinical team as to the trends in systolic and diastolic blood pressure that people should be notified. So we specifically give them thresholds for systolic blood pressure. They don't even have to meet hypotension, but we want to know ahead of time so that if it's needed, the baby can get the orders in for whatever inotropic support they might need, but also for an organ perfusion routinely and for evidence of persistent systemic hypertension, even if the baby is already on Mirinone, and especially if that hypertension is diastolic, because that might be a trigger for people to increase Mirinone or do some preemptive changes on the baby's care. This is a slide that I always have. Many of you probably have seen it before, but this is a summary of kind of the management strategies that we have for the different presentations of post-PDA closure, cardiorespiratory instability. And then I just want to kind of finish off with a couple of newer data. First of all, I wanted to highlight what are some of the unanswered questions that we have that might be a good discussion for the panel. First of all is we need more studies to further delineate what is this respiratory phenotype, and perhaps we can use new modalities such as lung ultrasound and so on and so forth. We need to understand a little bit better what is the role of Mirinone in transcatheter closure, either in the prevention or in the treatment for PTCS and all of its components. Does giving Mirinone actually prevent perhaps the cardiovascular compromise, but not the respiratory? We don't know that. We also don't know what are the thresholds for giving Mirinone, whether those thresholds should be echo-based, clinical-based, or stratified by risk based on the patient population. What is the correct dose of Mirinone to be used? We only have data that we just published on systemic hypertension in the very short term, which is those first 24 hours. Is there actually a higher risk for systemic hypertension in the long term or long-term impact? What is the role of the renin-angiotensin-aldosterone system? What is the role of cytokines, of inflammation? How is that different perhaps in the endovascular approach versus the surgery approach? What is the phenotype of systemic hypertension in the association with those LV diastolic markers and the respiratory compromise? And then one more of many ideas is what is the long-term data on respiratory, cardiovascular, and neurodevelopmental outcomes, both in cath surgery patients, but also categorized by having PTCS, yes or no, having received therapies, yes or no. And coming up shortly, we are going to launch the MIDAS trial, which is Mirinone for the prevention of PLCS. This is an NRN study, which will be a multi-center, double-masked, randomized placebo-controlled trial, including patients that are less than 28 weeks and less than 2 months who are going for either cath closure or surgery of the PDA. These babies have to be on invasive or non-invasive respiratory support and have a hemodynamically significant PDA within 2 days of intervention. And what we will be looking for is the primary outcome of PLCS or death within 7 days of PDA closure. We're hoping to get some short and long-term clinical outcomes, hypertension, oxygenation failure, neurodevelopmental outcomes, but we'll probably get some data also on the safety of Mirinone and adverse events, since there's a drug that is not FDA approved for premature babies. With that, I conclude my talk, and I am happy to participate in the panel or answer any questions that you guys may have. Thank you.
All right. Thank you very much, Dr. Bischoff, for that very thorough and insightful exploration of the topic. You provided us with a clear understanding and excited to hear more about the new phenotypes. So joining us to kind of answer the questions as our panelists and have more discussion, we have Dr. Shyam Sathanandam, who is the Director of Interventional Catheterization Laboratory and Director of Clinical Research at the Heart Institute at La Bonne Children's Hospital. He's also the Director of the Large Animal Cardiovascular Research Center and Professor of Pediatrics at the University of Tennessee. And we also have, all the way from Canada, Dr. Gabriel Altit, who is a neonatologist at Montreal Children's Hospital in Quebec, Canada. He's the program director of the Neonatal Hemodynamics Research Clinical Fellowship and founder of NeoCardio Lab at the McGill University Health Center. And then we have Dr. Phil Levy, who's from this side of the pond. He is an assistant professor of pediatrics at Harvard Medical School and a staff neonatologist at Boston Children's Hospital. His patient-oriented and translational research initiatives focus on cardiac mechanisms in congenital and acquired cardiopulmonary disease in children. So I will hand over to my co-moderator, Michael Castaldo.
Thanks, Marjorie and Adrianne. Fantastic talk. Thank you so much. That was informative, insightful, and incredibly relevant. Phil, Shyam, and Gabriel, thank you for joining us. And I'm going to try to pepper all of you with questions throughout this. Marjorie, as well, has got some lined up for you. I'm also going to keep a sharp eye on the Q&A section. So people, please fire it in that direction. We'll take a look and make sure we represent what the group is pining to ask. However, before I delve into that, and Laura, I might need a bit of help from you, I'm going to plug a very important a course that's coming up, and one that's near and dear to many of us, in particular to me. So I want to plug that in November, starting on November 11th, going to the 14th, there's the annual Dr. Reagan Giesinger Clinical Cardiopulmonary Physiology for the Care of the Sick Newborn course, the European edition, that I'm going to encourage, if we can get the QR code up, to click learn more and register. Reagan obviously was impactful to many of us. She was an incredibly dear friend to me, a colleague, and an inspirational mentor. This is such an amazing thing to have annually to do in memory of her incredible drive to move this particular field of medicine forward. And so please, there it is in front of you. Don't forget about it. Such incredible objectives that are listed there. And so take some time. Don't forget about registering. So without further ado, I'm going to start with Adrianne. Adrianne, thank you so much again. The talk was incredibly helpful. I want to bring back to some practical guidelines that you were an active member of developing and forming. And one of the things that your clinical guidelines recommended, that in lack of the high certainty of evidence of patient important outcomes, one of the things when talking about choosing a pathway for PDA management was about involving the family, making a shared decision-making process. And that is becoming more and more relevant as we have so many different pathways, from the conservative to the pharmacological to the surgical to now the transcatheter approach. I want to ask you, in your center, in your experience, how pragmatic is that? And could you describe how you are approaching families with these options? And how can this be formatted into future clinical guidelines? So, Adrianne, if you could tackle that question, love to hear it.
Thanks, Mike. Yeah, that's a really good consideration. And when we wrote that, we try to talk between ourselves. How are we going to recommend this? What is the right way of doing it? Because as we all know, each family is very different, and how they want the information to be presented is also very different, right? Some families do want kind of a more prescriptive, what do you think it should be done? We will just do whatever the physicians will recommend, whether that's endorsed by high certainty evidence or not. Whereas other will want a little bit more of details and a little bit of more evidence and a little bit more numerical information. So it is a challenge to identify what type of family, where in the spectrum the families fall. I think so we're not very pragmatic in that regard. I wouldn't call us that way, but we try to just be transparent and honest. You know, in our experience, this is what we would recommend based on these factors that we're seeing on your baby's echoes, on your baby's clinical presentation, on your baby's clinical trajectory. Having said that, this is a new technique, and there's still a lot of studies that are coming out of this to define if there is not only technical success and short-term benefits, but longer-term benefits. And we just don't know. those answers. From the best of our knowledge, this is what we would proceed with, and we just try to be honest about it, and then see what type of questions they have and where they're falling. And I will say that 99% of the time, they will literally just say, what would you do? What would you recommend? And then we'll just say, we're talking to you because we think that this is probably the right way to go. And they will just go with the flow. That's kind of what it usually is. But I think just having that, that ongoing thing of making sure that you're expressing that there is no certainty and that you're just doing what you think it's best. And you might find out a couple of years from now that that might not have been the best thing to do, but just being transparent and making sure that families are aware of that.
Thanks, Adrian. Completely understandable. It's not easy. I'm going to actually pivot to Shyam. I know you're probably faced with these same kind of decisions when talking to families prior to procedural. How do you approach that? And what have you encountered when facing families who are being presented with this option?
Yeah, thank you so much. First of all, Adrian, wonderful talk. I think the work that you all have been doing has been one, amazing, and number two is, I think, very needed. So thanks for taking the lead on all this. So no, thankfully, I'm the proceduralist, so it makes my job easier because I'm sure the neonatologists are faced with 4 times more patients that they have to discuss this with before they involve maybe the proceduralist for one of these 4 patients, right? So for every patient that's referred to me for a transcatheter PDA closure, I'm sure there are 3 other patients that they've had the discussion and maybe decided not to refer for closure. So over the years, our success has been, yes, to be pragmatic. So not every patient needs this done. It's very hard to identify which patient was actually going to benefit from the procedure. But typically for us, if a PDA is quite large, which means on the echo, there's no signs of constriction along its entire length of the duct. So it's like a long tube, basically open on both ends, with equalization of pressures in the aorta and the pulmonary artery, with flow reversal in the aorta, which is throughout diastole. We don't look for left heart enlargement because I think left heart enlargement sometimes is a little bit later sign, or if there's a PF4 and ASD, the left heart never enlarges. So we don't really focus on that. But if the patient has to be on mechanical ventilation. For us, if the patient cannot extubate for some reason, which we think may be the PDA. So then we'll present this to the family and say that even though the evidence may not suggest, but your child may be the one that may potentially benefit. We don't know that, but may benefit. Do you want to talk to the proceduralist about this? And if the family is willing to talk to me, then I'll go over the procedure, the risks and benefits and alternatives of the procedure. And if the family is willing, then we'll proceed with the procedural closure. The one thing we do differently is we don't actually take the patients to the cath lab. We do these procedures in the NICU at the bedside with the patient still in the incubator. So we don't have to break the ventilator circuit to move a patient, things like that. But which is a newer, what should I say, as the evolution has grown. After our 300th case, we moved to the bedside. We've done about 150 now at the bedside. And I am totally of the opinion that this is a procedure done at the bedside. There's no reason why we should move this. And I think the interventional cardiology community will be eventually heading towards that. I think eventually, everybody is going to be doing this at the bedside. So this will become a bedside procedure. And but to answer your question, yeah, that's kind of our policy. We identify patients we think may benefit. We don't know whether they will or not, but the families have to be open to it. Thanks.
Sure. You opened up an avenue for me that actually tickles another interest of me, and that's transport. Are we at the point, this can go to you, Shyam, this can go to Phil, this can go to Gabriel, Adrian, anybody. Are we at a point now that if we need to move a patient that isn't at a high volume center that has a PDA, are we willing logistically to take on the risks of the morbidities of transport and transfer to get to that high volume site, which I think we probably all agree upon that we should be doing these at specialist centers that have high volume. Are we at a point now that we're advocating to move patients for this particular procedure? And this is a question to everybody. But I'd like to kind of hear what the people think on that aspect.
No, if I may start out, because I've been doing this procedure at the bedside, not only on our hospital, but other neighboring hospitals. The way this kind of progressed for us was as you bring out situations where very, very critically ill babies, who are stuck on high frequency ventilator, inotropes, poor urine output, very high risk for transport. We were transporting these patients from a different hospital to our hospital and then do the procedure and then transport them back. Now the risk is actually for the transport. The procedure, we've done enough of these procedures that it's, for us, I mean, the analogy I use is if you're doing a PICC line or something in the bedside for the patient is actually more invasive than PDA closure for us, because it's become such a very less invasive procedure. I mean, minimally invasive, I should say. Okay, so the procedure aspects we've taken care of, but the transport is the highest risk for these patients. So we started doing this procedure at the bedside in our hospital till we got the expertise to do this. And now we started like moving to other hospitals, so we don't have to bring these patients over. I think the risk of
I think Shyam may have frozen there.
Yeah, we lost him.
Oh, I'm going to say
Oh, he's
this.
back.
Okay, Shyam, sorry, you just we lost your last point there.
Sorry, I don't know when I froze, but I don't think there is risk for transport. And neonatologists, you all know it more than I do. Eventually, as the procedure evolves, we may, as the interventional cardiologist, going to travel from hospital to hospital, maybe doing this procedure. So we'll see what the future holds.
Gabriel, Phil, anything you want to comment about that topic? I've got a couple of other questions that I selfishly want to ask, but I also want to give everybody a fair shake. Anything on this topic?
For transport, I think it depends the infrastructure you have in place in the different jurisdiction and the different states and which hospitals are in your systems and things like that, what kind of expertise you can get. But I still truly believe, best outcomes come from, volumes and teams that are put together, right? So I don't think that, we could just pretend that if we do 1 or 2 per year, we're an expert center and we know how to care for these patients in the selection as well as during the actual case, or the procedural. But also, I think Adrianne really outlined so beautifully how much these patients are still complex even after the procedure and how you need to have comprehensive assessments that are being done at the bedside and tailored therapies based on that. So, I think if the outcomes are going to be improved, it comes with a whole package. It's not just like the moment of the procedure. It's all of this that comes together and the follow-up after that to make sure that, the patient is actually improving and benefiting from the treatments that you're incorporating within this kind of cocktail mix of things that you're doing. So the more volume you do as a center, and I'll be completely honest, our center is a very low volume for that. So I wouldn't pretend that we're expert at managing these patients. I would probably solicitate the help and support from like experts out there if we have cases that we're doing earlier and earlier. And in that sense, I think as a community, we need to work together. And that's why we have beautiful seminars like that to put in touch with some of these experts there to try to better understand how we should manage these patients, how we should select them, how we should counsel the families, how the cardiologist should work with the neonatologist and potentially with anesthesia also and all the allied healthcare professionals as a team at the bedside and during that post-procedure care, which is very important.
Gabriel, you mentioned just quickly, obviously you come from a center that has embraced the conservative non-interventional approach. Having kind of starting to read the literature, hearing this lecture today, is there a patient that would walk into your unit that you would say, I have to consider this? Or is that something that at this point you have the outcomes that you're happily aligning to?
Mm-hmm. I think at the end of the day, every case is, every case you're going to manage based on the case properties. So I don't believe in medicine that is always and never. I think it's always has to be tailored to how the patient is behaving, responding to treatments, depending also on the choices or the discussion with the families on comorbidities that the patient may have, contraindications for certain approaches or no contraindications. So I don't see or foresee that something is completely out of the line or out of the book. Yes, we are more of a conservative approach. It doesn't mean that we haven't placed some piccolos in some patients here also. So it does happen, but I think it's always like a consideration that you have to do as a team approach and based on the patient you have in front of you. So definitely it's not something that would be completely out of the line.
Thanks for sharing that. Adrianne, thanks. I see your hands up.
Yeah, I just wanted to highlight, I think there's two aspects to this question, right? One of them is I firmly believe that right now we have to keep doing this in high volume centers, both from a cath expertise as well as a post-procedural care. I don't think we're ready to start doing this in smaller locations where, sure, Sean may go there and close the PDA, but are they going to be qualified to be taking care of the baby afterwards? So that part, I am pretty pragmatic that I think we should be doing this in high volume centers. But I think more to your original question, Mike, your question is, do we have enough evidence to say that we have to transfer a baby for PDA closure? And I think that needs to be individualized. If it is obviously a baby with AKI, has already had necrotizing enterocolitis, has a shunt that is undoubtedly causing issues, yes, you have to take the risk of transport and do that PDA closure that you believe might influence the outcomes of that baby, both in the short and in the long term. Whereas if you have that baby that here in Iowa we might close, who is the baby on CPAP in 21%, then perhaps those ones that's more of a gray nebulous zone, because then you have to, there's not as much risk to transport, but is there going to be a benefit as well? So that needs to be more individualized as well.
Yeah, I think, Adrianne, the logistical kind of considerations could be incorporated into those guidelines that some of them you just touched upon. Phil, a lot of questions from the Q&A are talking about the predictability of post-procedural cardiac syndrome. I know you published on some of the subsequent short-term respiratory outcomes and phenotyping these babies who've had ligations or transcatheter closures. Can you maybe touch upon a little bit about what you have found in your look into this body of work and share that with us?
Sure. Thank you. And I echo the comments from the other panelists. Adrianne, the talk was wonderful, and it seems to get brighter and better every time I hear it. So thank you. In terms of the respiratory phenotyping, I'm not going to talk about the long-term impact on BPD or pulmonary hypertension. We can answer that if there's time, but it's more the kind of the post-closure cardiac syndrome that we're seeing, where there is a respiratory phenotype, which you can go and look at the definition with an increase in FiO2 or troubles with ventilation. We were trying to understand which babies would go on to have more respiratory complications following either surgical ligation or device closure. So using kind of all of our historical data, then using some prospective data, and the caveat being that we're not in a center where we are putting the babies on the jet at 22 weeks and keeping them for X amount of time. We were getting all comers. And what we found was not necessarily novel. Shyam had looked at some of this metrics before, but really applying it across the board using something called the respiratory severity score, which a very simple metric that all of us can use, just using the mean airway pressure times the FiO2. So mean airway pressure of 10, and if the FiO2 was 50%, 0.5 times 10 is just 5. And what we found from our own data, which is not unique, is that if you had a respiratory severity score higher than 4, 1 hour before device or surgical ligation and 1 hour afterwards, you were more likely to escalate on your respiratory support, and you were more likely in our cohort to end up on high frequency ventilation. So how do I translate that into real world physiology and practicality? I think Adrianne highlighted in her work that there is this kind of honeymoon period. You close the PDA and it almost feels like the first hour, 2 hours, their gas is great. Maybe they're over ventilated and the x-ray looks great. And you make all these weans and these changes, and the procedure is done at 3 o'clock in the afternoon, and you go home and your colleague, when you see them the next morning, they said 6, 7, 8 o'clock at night, 10 o'clock at night, the kid fell apart. And what we've learned from all of this and from my own work is that you just don't rush to kind of de-ICU or demedicalize this patient. So if they have a respiratory severity score higher than 4, we will empirically sometimes put the kids on high frequency ventilation after the procedure. Or if they were on some level of support, we say we're not going to wean the support for the first 6 to 12 to 18 hours until we have our echocardiogram. We also, in our paradigm, if they were never on sedation beforehand, we'll add sedation. If they're on sedation, we'll go up by 10%. All of these things to mitigate kind of the catecholamine release, the increase in PVR, and this post-respiratory phenotype. So I think it's just another way to look at the same question that Adrianne has so nicely highlighted.
So
Phil.
Phil, I have a follow-up question for you. Within your protocol, are you guys also using the 1 hour post-cath closure echo when possible and utilizing that to give prophylactic milrinone? And then about how long are you waiting after the procedure to send the babies back to original center? So that's 2 questions for you.
Great question. So we do an echocardiogram within about a half hour after the closure. We try and do our echocardiogram right before they leave the cath lab. So we have an echo, obviously, like many of you, where we do the echo before, during, and after closure, and then we'll get an echocardiogram. And basically, we're trying to standardize the approach and use very similar processes where you're looking at LVO, so forth and so on. But initially, when I joined the group in Boston, we were not using any milrinone, and we were not using kind of quantitative echocardiography to make these decisions. But over the last 2 or 3 years, since we had Michael Ferraris, who's our cath guy, come back from Florida, we have become more of a center that is using milrinone. And it's based on kind of some quantitative and qualitative features of that echocardiogram about a half hour after device closure. And Adrianne nicely highlighted, there's so many questions about the use of milrinone, and do you use higher doses in bigger babies and lower doses? And do you give a bolus? Do you give fluid? All of these different questions need to be answered. But typically what we do is we'll start the milrinone. We started anywhere from 0.23 to 0.5. We get an echocardiogram within 12 hours. It's usually just the next day. And if there's good function using qualitative and quantitative measures, then we will half the dose, and then we'll shut it off by 24 hours. Our goal is to send the babies back within 36 to 48 hours if there has not been an acute decompensation. Some of that's limited. If some centers can do milrinone and some centers can't. So that goes into the discussions that Gabriel talked about you have to think about your local and statewide practices of what they can and cannot do. But our goal in general is to get them out of our institution within 24 to 48 hours after the procedure.
Okay, thank you.
I'm going to ask the question, in centers that are using still a multiple approaches, be surgical versus transcatheter, can I ask the question, who still gets ligated? Is there that kind of bifurcation or decision-making model that some still get ligated in centers that are placing device closures?
Here in Iowa, you get ligated if you are really small. So if you are around the less than 600 gram mark, or if there was something that happened in the cath lab. We had 2 babies that were not able to get femoral access because of clots. One had a clot in the IVC and one had a clot in the femoral vein, and the other vein had, I think, a PICC line or something, so they couldn't access. So there was an actual contraindication for endovascular access. But for the most part, the babies that still get ligated are those really, really tiny ones. And as we're doing 21 weeks, 22 weeks, and severely growth restricted babies, unfortunately, those babies still happen. But it's a relative infrequent occurrence here.
Yeah, I'll tell you, in Memphis, the last ligation we did was 2016. So we haven't had a ligation since 2016. So 8 years now.
Huh? So what is the smallest baby?
Sorry.
Oh, sorry to cut you off. I was asking the smallest baby that has received a transcatheter closure in US center.
So I can answer that. And the size doesn't really matter. I think there's no big difference between a 400 or a 600 or 700 grammer. They're all the same. The size doesn't matter. For me, the tissue maturity is what matters. So let's say, so I did a closure on a 23-weeker, which was 5 days old. I can tell you that tissue was a lot less mature than, let's say, you take a 24-weeker that's 2-week-old. The chance of a complication is less, even though the procedure went great. The 23-weeker, 5 days old, the procedure went great, but you could see that this patient is not mature enough for a procedure, we got the expertise now that we could do the procedure very fast and very safe. We don't need any hemodynamic compromise during the procedure, and that's been our aim. And the more we find is that if you have almost no hemodynamic compromise during the procedure, we don't see the post cardiac syndrome that's been described as much as we used to see in our experience. The second thing is, in our center is one that does not use milrinone. Like, I've not used milrinone on any of our patients, but we use calcium. So we use intraprocedural calcium. Now, I feel that has kept our patients so stable during the procedure and post-procedure. Again, we'll see if that's something important, because I don't know how to explain it. I do think these neonatal myocardium are very calcium depleted, even though the extracellular calcium level is normal. The intracellular calcium is very depleted. So sometimes we kind of giving this extra dose of calcium may keep them more stable. And I've done that for hundreds of babies now, which seems to be working. So I'm not changing practice at the moment, but we'll look into the milrinone. Again, time will tell what's the best way to do this.
And can I ask Dr. Shyam one question? What's the timing you typically will consider a closure in your population? Is it like more on the earlier end? I know some centers are still having a practice where either there's going to be a watchful period to see if the ducts will spontaneously close, or there will be interventions like the protocol that was outlined by Dr. Bischoff with Tylenol and endo courses if necessary. Do you tend to go as a primary intention with that? And is that at an earlier stage, which may also potentially explain why there's less cardiovascular or cardiac remodeling?
Yeah, that's a great question. So now, as you know, the PDA Tolerate trial, I think one of the major findings was if you're on a mechanical ventilation and with large PDA that's hemodynamically significant beyond 10 days, there may be a higher incidence of BPD. And I think that may be what we kind of utilize for decision making. So by day 10, if someone is still not extubated, and as I said, the duct has to have no constriction along its length. For us, that's the main echo criteria. And if that's the case, we would consider closure. Now, we'd always try to do medical therapy if there's no contraindication as the first line. If there is contraindication, then do primary transcatheter closure. So this, I do believe the second week of life may be the right time to do this. So typically for us, it's the second week, maybe the third week, but beyond third week, I think most of these ducts are either closed or not significant.
Mm-hmm. And Dr. Bischoff, in your practice, is it a tendency that I would guess closer to the end of the second week or maybe the third week from your data that I've noticed?
Yeah, for the most part, I would say, I don't know the true number, but the median age at procedure is around 21 to 30 days of life. So third to fourth week of life is the most common. There's very few that are second week of life. And there's essentially, I think the youngest was maybe 10 days. And that was a one-off.
Can I ask one question, Mike? I know time is flying, but there's one aspect of the presentation that was fascinating is the whole idea of the whole diastolic, picture and the RA activation that may happen in some of these patients from their chronic shunt that has happened. I was wondering if Dr. Bischoff could only give us some insights about if some of these patients also have interatrial shunting of different volumes and different size. And I'm wondering if she's noticed certain patterns in some of these patients, because I would think that if you have significant LV diastolic dysfunction, maybe your PFO would be more stretched or, higher velocity because your LV pressure starts rising. So I'm just wondering if you've seen anecdotally some of these patterns or noticed some of these patterns, and if you think that the presence or absence or the degree of the presence of this interatrial shunt or the magnitude of the interatrial shunt also impacts the decisional process when you guys decide to go to the cath lab.
Yeah, those are good questions. I have not looked at that in a scientific way. No. So looking at all the patients, measuring and analyzing it, no, we have not looked at it. I also have not noticed any trends. Perhaps I'll pay more attention going forward after you asked, but it's not something that I've observed. Typically what we see immediately post cath closure is that the PFO that tends to be a little bit overstretched or very much left to right, higher velocity, actually becomes small, kind of floppy, and frequently even a little bit bidirectional, probably because of that deflated balloon type of effect. So I haven't seen any, oh, wow, this is a very impressive left to right atrial shunt that might be impacting our findings.
Want to give Phil an opportunity to comment on some of the things that have been said, but also on the topic of who still gets ligated. Phil?
Sure, thanks. I'll try and be succinct. So we tried to look at that on our own data. Haven't done as many device closures as Shyam, but since 2019, approaching the 175 mark, with a huge referral program. And unfortunately or fortunately, we've done about 5 ligations a year. So somewhere in that 5 ligations a year, 25 to 30, and again, about 175 device closures. When we looked at the data, the kids who still got ligated were the kids who had active neck, and we thought the PDA was causing more harm than good, and we couldn't wait for the PDA to go away. So those kids, we would do a bedside surgical ligation. The other kids were bacteremia. Now, it's not to say that you couldn't wait to the end of the bacteremic course to then put a device in, but for whatever reason, it must have been early on in our learning curve. And then for morphology, which is a little bit controversial, if the duct is too kind of small and a device would stick out, or it was too fat and juicy. But that, even amongst our own group, is a little controversial, because there are people who would always just try first before going to ligation. There's others who would not do it. So again, there are some reasons. And then to Adrianne's point, some of the really small ones. The smallest we've ever done in Boston is 550 grams. And we have seen what has been reported in the literature, some of the LPA stenosis, but I'll leave that for a whole nother discussion. But it's not to say that it's not a tool in your tool bag. Some of the other comments about the timing, I think I've looked at this many different ways. If you're in a place that you wait for symptoms to decide to get your first echocardiogram and decide on pharmacotherapy, or you're in a place like Iowa where you could do risk-based assessment with hemodynamic screening, no matter how you slice it or dice it, I do agree with Shyam that the earliest I would consider device closure is no earlier than 10 days. And I think the literature sort of bears out to that. And you can think about how many courses, that's a question I always get. How many courses of pharmacotherapy would you try before going for device closure? If the kid's not in imminent danger with end organ perfusion, then oftentimes people will recommend at least 1 to 2 courses. The idea of doing a third course, there is some data where there could be benefits, but there's also people who say I wouldn't wait to do a device closure at the expense of a third course. And then the final comment is with the calcium. It is interesting. I think we need more data on what Shyam is doing. I don't think it's necessarily harmful. I also, the sarcoplasmic reticulum is just underdeveloped in general, and it's amazing that milrinone even works on the sarcoplasmic reticulum in a preterm infant. But I am just fascinated by the calcium discussion, and I think we need more animal studies to really decipher this. But I think both pathways are correct for the moment.
I'm going to do a bit of a baseball move. I'm going to go to the bullpen, and I'm going to bring in the closer. It's Dr. McNamara. I have a question for you. Why do we need Midas?
Oops, sorry, Mike. I think the discussion answers the question. There still is controversy. I think, biologically, the data on progressive hypertension and the potential association with the renin-angiotensin system kind of pretty much confirms that afterload, is potentially an issue. The data of benefit is very much left to individual institutions, but I think of interest on I don't think Adrianne touched on it in the multi-center study. The incidence of hypertension was, I think, 5-fold lower in the site that used kind of milrinone, as were kind of the instance of some of the respiratory outcomes. So I think that's at least hypothesis generated. And Adrianne, correct if I'm wrong, but I think we're also using calcium. I think our interventional people are giving calcium as well, kind of in the cath lab for the procedure. So
yeah, they were doing it, and we did correct for that in our multi-center analysis, and nothing came up.
Okay. So I think the bottom line though is that one of the main things that's important for us as a neonatal community, the use of milrinone in preterm babies has gone up exponentially, more than 1,000-fold in the last 10 to 15 years. We have no randomized control trial. The only RCT of milrinone in children is the Hoffman trial, the Primacord trial, which included no preterm babies under 37 weeks gestation. So I think from not just from an efficacy perspective, but from a safety, I think it's really important to actually look at the long-term outcomes of milrinone use. I think this study design, I think is a perfect opportunity, not just to test the question in terms of efficacy, but also to look at the safety of milrinone, as it's a drug. If your kidneys don't work, if you're asphyxiated, whatever, there can be potential issues from that perspective. So I think that's why we need MIDAS. Plus, we have done a very bad job in neonatology at actually conducting RCTs of cardiovascular pharmacological interventions. There's next to no data. So
thank you for that. And I see that we're at 12:15 now. And so there's been a number of questions. Thank you to the panelists for actually answering some of those questions directly. But I would like to thank everybody who joined today. My co-moderator, Marjorie, Gabriel, Shyam, Phil, amazing discussion. Thank you for all the contributions, both today and in the literature that you provided. And Adrianne, just a fantastic presentation, as always. And I'm just was incredibly privileged to be amongst this group. And so I wish everybody an incredible day, the rest of the summer. And please don't forget about that upcoming course in November, honoring the teachings of Dr. Reagan Giesinger. With that, I say goodbye. Thank you for joining.